Good afternoon, everyone, to my esteemed judges and the audience. It's a pleasure and honor to be here. Today I will be talking about the effect of cap depth in smile on various factors in the eye. I have no financial disclosure in the public matters of this. So we all know that in refractive surgery, the corneal nerves can be transected, and corneal nerves have a very important role to play in how the eye heals. So we're always looking to see which, it sort of highlights in our mind which surgery, LASIK does more nerve transection, SMILE does less, PRK, we don't know. So we're trying to compare it. But what is established now for a fact is that definitely in SMILE, the nerve transection by the lenticule plane, which has been created, is less. So, and following that, the re-innervation is higher after the SMILE compared to the other refractive surgery modalities. So, over time, there have been multiple studies which have shown that this nerve preservation and regeneration is much better. But what is an important point to keep in mind is whether this fact of whether the nerve regeneration is faster, the nerve regeneration is better, does it clinically correlate and translate into a better healing and a better outcome post our surgeries? So this diagram just shows that even though we know that the SMILE, the cap, both the anterior and the posterior incision which is there does cut various parts of the nerve plexuses, and we wanted to know whether we can achieve a better nerve preservation if we do a deeper cap depth, because we know that many of the main subbasal nerve plexus is a little more superior. And also, if we are doing a deeper cut, we are closer into the stroma, we are closer to the density of keratocytes there, are we inducing more inflammation, and would that also affect the outcomes in these patients? So the knowledge gap we were trying to assess here is whether there's more, a change in the nerve regeneration, whether this would translate to a difference in inflammation, and overall how it would impact our wound healing. So this is our research question that we were trying to assess. In this patient, we had all patients who were undergoing SMILE. The age group was 20 to 30, and it was a prospective randomized study, and it was a contralateral eye study in which one eye had a cap depth of 100 microns and the other eye had a cap depth of 150 microns, which was randomly assigned. The usual exclusion criteria, which we use for refractive surgery, including any abnormal topography, dry eye, severe dry eye, scarring, were taken as our exclusion. So this is the kind of workup which again is quite routine, except for the addition of a confocal microscopy to assess the nerves. We also looked at the optical quality in great detail. The dry eye evaluation is part of our routine workup, so that was followed, and the tear factors to look for the inflammatory markers. And all of this was done preoperatively and at 1, 3, and 6 months to compare how these eyes were doing. All the surgeries were performed by a single surgeon on the same platform, same cap diameter, lenticule diameter, and the energy settings and laser parameters were also similar to avoid any confounders between the two groups. These were the outcome parameters that we looked at. As I was saying, the visual acuity and the quality of vision we compared. This was done by the optical quality analysis system. We also looked at the nerves by the confocal microscopy, in which we looked to see how the density and the features of the subbasal nerve plexus were. The epithelium is very, very important because it gives us a good measure of how the wound healing is happening, and if there's any irregularity preoperatively, that was also not taken. And the dry eye parameters by the Schirmer's TBUT staining and the tear molecular analysis, which we did by the ELISA. So coming to our results, it was interesting to note that at 1 month, the group which had a 150 micron cap depth had a slightly less amount of dryness as compared to the 100 micron cap depth, although no patient in this group developed a severe dry eye. However, this difference reduced significantly over the 3 and 6 months, which means by 6 months, most of the patients were comparable across the two groups. So it was only the initial change which was significantly different. Again, what is quite reassuring to note is that the visual acuity, both the quantity and quality of visual acuity and the epithelial thickness, the epithelial changes were not significant between the two groups, whether the 100 or 150 micron. Again, even the biomechanics did not show any difference, which is again heartening to know. Even if we are cutting deeper into the stroma, the biomechanical strength at follow-up was very good in both the groups. Here's where we really wanted to add some value. If we have seen a change in their dry eye parameters, how can we explain this? So the subbasal nerve plexus density actually showed that there was much better preservation of the nerves in the 150 micron and a much faster regeneration of the nerves as well. And this could be one of the reasons why the initial dry eye is a little less in the 150 micron group. Interestingly, there was not much of difference between the inflammatory profile again of the 100 and 150 microns, but what was seen was in the deeper group, there was a change in the extracellular matrix modulators, and this could then be correlated to the fact that it's a deeper cap. So the dissection in the deeper plane could change the wound healing response. However, as we saw, the clinical correlation to this is that by 6 months, they're both doing very well, and that is really heartening. There have been excellent papers which have shown that the different cap depths have a very good clinical outcome. This is what we saw, that the early nerve regeneration is there in the deeper caps. I'll just close with this. So even though we know that the subbasal nerve density is good, we did see that in the 150 micron group, they reached much faster, so their recovery was a little closer. And how we can apply this in our results is that because the 100 micron group had a little more dryness in the initial phase, there was a little change in the inflammation. Maybe, we can look at the clinical surrogate markers, and in a patient who has a pre-existing inflammation or contact lens user, or we are suspecting they may have dry eye, we opt for a slightly deeper cap depth. Thank you very much for a patient listen.
Thank you, Sharon. Dr. Sri Ganesh.
Yeah, nice study. We have done this study and published it in International Ophthalmology. And we also found that at the 160 cap, the early dryness was less in TBUT, but by 3 months there was no difference. I wanted to know whether you had any nomograms. Did you change any nomograms between the 160 and 100? Because there was another paper that was published. I don't know the institute, which says that you can have undercorrection in the, if you go with a thicker cap, and so you need to have a nomogram adjustment.
No, sir, we did not do any nomogram just for this. It was similar across and just based on the refraction.
Did you do any energy adjustment? Because again, when you're going deeper, the corneal fibers are thicker, and so you may have a need for more energy to cut these, and otherwise dissection. You can have difficult dissection.
No, sir, we didn't. We kept the same energy.
You kept it at the same energy. Sharon, and you said you did OCT. So did you look at Bowman membrane distortion? Because with a with a thinner 100 micron cap, you can have more Bowman's membrane distortion than at the 150 cap. So did you look at it?
We did look at it. It's not part of the study, but we did look at it because we had the similar thought process. But we didn't see too much of distortion between the two groups. It could be, of course, that it's the same surgeon doing, and that the ironing and all is part of the routine protocol. But there was no significant difference between the distortion.
Did you find any difference in the OSI between the two groups?
No, sir. That I showed. No, not there. So we expected all of it, but nothing significant, which is great.
So very nice correlation of various aspects that you put together between the two levels of the cap.
Thank you.
Is it even significant to consider the deeper stromal plexus, or is it too far away that it will not play any role whatsoever between the two levels of flap?
No, ma'am, that's a very valid point. So at 150 microns or 160 microns, some fibers or the trunks of the deep plexus could also be transected. The only point there is that because they are much fewer, we may not always, get them in our image repeatably. So measuring them becomes a little more difficult.
So I was just thinking that we should not save something and hurt the other thing inadvertently.
Yeah. But it won't be the main trunk. It will be
and it's probably not as relevant in dry eye causation as the subbasal plexus.
Yes, ma'am. Thank you.
Dr. D'Souza, you have said that both the groups had a similar outcome at the end of 6 months.
Yes, sir.
So should we shift to a 150 flap now for all cases?
No, sir. There's really between. That's what we were trying to see, whether there's any reason to shift to for all cases, but there's no requirement for it. Sometimes if we have a
150 will give you advantage. If you have to do a resurgery in those cases, you can do a re-smile Or you can do a flap-based LASIK also, thin flap LASIK.
Yeah, but what we did see was that some of the extracellular matrix factors were, more proliferated in the deeper cap. So we don't know if over time, long-term follow-ups, if they may have some change. So, but we'll stick to our original.
Corneal biomechanics did not show any change because as per the mathematical modeling by Dan Reinstein, if you have a thicker cap, then you're preserving the anterior lamellae, which is stronger,
more contributing
so you expect
to
a better biomechanics. But there was no difference.
No.
Thank you, Sharon.
Thank you.
Very good.